Good afternoon, good morning, and good evening. Welcome and thank you for joining us today from around the world and especially from East Africa. I am Kevin Simiu, and on behalf of the Aga Khan University, I am delighted to welcome all of you to our Connecting AKU webinar series. This series is especially curated to share AKU's transformative work. Welcome, and over to you, Gitonga.
Thank you very much for that introduction, Kevin. And it is indeed a pleasure to be here today with all of you. And once again, good morning, good afternoon, and good evening, depending on where you are in the world. This is an exciting time as we look at this topic of healthcare in East Africa, public healthcare in East Africa and its future. The pandemic has brought upon us many strange questions and many different approaches, innovations, and challenges nonetheless. And we want to explore some of those particularly in our region today. As mentioned earlier, our guest this afternoon is none other than Professor Lukoye Atwoli, and he will be with us today to tell us about some of these. Professor Lukoye is, as was mentioned, the Dean of the Medical College East Africa, and that is the unique model we have. It's East Africa, Kenya, Uganda, and Tanzania. He is a professor of psychiatry, a mentor to master's student and PhD students, a researcher, an external examiner. He is also the visiting scientist at the Harvard T.H. Chan School of Public Health, served as a vice president of Kenya Medical Association, is an international faculty member of the Global Health Institute, and very interestingly, a fan of suspense, thrillers, and science fiction. But we won't go there today. Those will be questions we will ask him on another day. Professor Lukoye, you joined us not too long ago at the Aga Khan University. Tell us a little bit about your journey coming here. It would be something interesting to discover about you.
Thank you very much, Gitonga, and thank you everyone for joining us this evening in Nairobi and elsewhere. I'll just begin by indicating that I was born in a small village in Western Kenya. So I spent my formative years, like any other rural kid 45 years ago, trying to find their way around the world. As soon as I showed interest in going to school, we moved to Nairobi and lived in the Eastleigh area, where I went to Eastleigh Airport Primary School, right next to the Moi Air Base. And soon after that, then I went to Jamhuri High School for my high school. And so, I mean, for the information of those who may not know, Jamhuri High School is one of the oldest high schools in Kenya. In the colonial days, it had been designated as a school for Asians because we had a system of segregation that was legislated akin to the apartheid system in South Africa. But subsequently, it was opened up to everyone, and I had the privilege of attending the school in the 90s. I went to medical school in Moi University in Eldoret, which is 375 kilometers from Nairobi. And at the time I attended the medical school, it was the second medical school after the University of Nairobi Medical School. So it was new, and there hadn't been any graduates by the time I went there. I was struck by the difference in approach from the traditional system of medical education, where the experts would stand in front of a class and pour out their knowledge, and the novices would pick up the knowledge and regurgitate it in order to demonstrate that they have learned. But at Moi, things were different. We had a lot more responsibility as students in the process of acquisition of knowledge. We had a lot more responsibility in doing research and discussing issues with our facilitators. But I was most struck by the community orientation in the sense that right from the first year, we spend a large amount of time in the communities around the medical school and in rural communities further downstream to understand the health challenges and the health problems of the communities that we were studying in order to serve. Another striking thing at Moi University was the collaborations that were set up. And these collaborations included international partnerships. And I had the privilege of spending some time at Indiana University School of Medicine as a fifth-year medical student, trying to understand health systems in other parts of the world compared to what we had in Kenya. After graduating from Moi University, I worked in Nakuru and in a rural outpost called Olenguruone on the edge of Mau Forest, where I address primary healthcare problems and the health challenges of a completely rural community that had very little access to other formal healthcare systems. And after that, I went to the University of Nairobi, where I studied psychiatry. And I have always been interested in psychiatry. When I finished high school, I went to study information technology at Strathmore College. And so when I was admitted to medical school, one of the things I said is that I will study for a subspecialty that is as close to information technology as possible. And luck had it that I later learned that this is psychiatry. And so I did my psychiatry at the University of Nairobi. And after this, I served the country in Garissa, near the Somali border, towards the Somali border, not too close, of course, but then it's the same region we used to call the Northeastern Province. It is a pretty arid area and comes with unique challenges, including challenges around trauma, challenges around deprivation, challenges around neglect of whole communities. And I worked there for 1 year before going back to Eldoret to start my academic career at Moi Teaching and Referral Hospital and Moi University. So I rose through the ranks at Moi University between 2007 to 2014, where I was appointed Dean of the Medical School. And I served for 5 years as Dean before retiring and going into some of the work that I like, working with young children, working with youth and adolescents in mental health. And it was at around that time that I encountered the Aga Khan University's search at the Medical College East Africa for a new dean. And I was intrigued. And my intrigue was in the sense of asking myself, why another medical school? Why do we have to do this? And so I did a little bit of research about what the medical college here was doing. And I determined that this was an opportunity to change the way medical education is done in the whole of East Africa. And this is one of the reasons that I took on the challenge and accepted to come to the medical college and see what difference we can make in medical education and in the health system in this country.
That's an amazing journey, Prof, if I can say so. And I think you are still in IT because you're working with the most powerful supercomputer, the human mind.
I know.
And so that's great that that's happening and that you joined us, your experiences in the rural areas and the different communities, community health-based, and you know the 4 pillars we stand on at AKU in terms of impact, relevance, quality, and accessibility. Putting all that in context, what are your aspirations of the Medical College of East Africa going forward?
So I see the Medical College East Africa sitting in a place where we are fulfilling that ancient Chinese curse of may you live in interesting times. We find ourselves at a time when we are pivoting already from being a predominantly postgraduate medical education institution to becoming a complete medical school that has an undergraduate medical program and numerous other postgraduate programs, including the residency programs that we already have. And so what I expect as we go forward with the energies that we're putting together, the resources that we're marshalling, is to develop an East African medical school that will be globally competitive, that will be punching above its weight if you look at where we are coming from, but training health professionals who are completely relevant in the East African and African context, but who are not at sea and have the capacity to be leaders on the global health scene. So this is where we are heading, this is where we are looking, and the preparations that we have put in place are basically set up in a way that assures that that is where we will be in a few years hence.
You mentioned something as you were talking there that I know has got a lot of ears buzzing, and that was an undergraduate program. Tell us a little bit more about that, because I know there are a number of people have been asked the question, hey, why don't you guys have an undergraduate program here in East Africa?
Yeah, so the medical college here has been a residency program for most intents and purposes. So we have residency programs and fellowship programs of specialty across most of the areas in medicine. But we asked ourselves, there are close to a dozen undergraduate medical programs in Kenya alone. And in Eastern Africa, I think you're going into 30s, 40s, numerous medical schools. all producing medical doctors in this region. You ask yourself, why another program? And we set out and looked at the environment and determined, do we really need another undergraduate medical program? And after our market research, after looking at what was happening, we determined that indeed we do need another medical program. However, we do not need another medical program to marshal the numbers, because the numbers will be produced by these dozens of medical schools in the region. But we need a medical school that creates a difference. The difference we are going to make is that we are going to transform medical education in Eastern Africa. The first generation of medical education in Eastern Africa, which I would call medical education 1.0, is what was being offered at Makerere University and University of Nairobi in the 50s, 60s, 70s coming forward. Medical education 2.0 in East Africa begins with the stories of Moi University, Mbarara University, and the others that have come subsequently. There are numerous other medical schools that have come that have adopted the 1.0 model, and some of them that have adopted the 2.0 model, and numerous others that have had a hybrid between what was done in the 1.0 model and the 2.0 model, which I would call the 1.5 model. AKU Medical College East Africa introduces medical education 3.0 for Eastern Africa. And this will be different from what we have had in the past, in the sense that one of the biggest determinants of how we do things will be how we use technology in modern medical education. And I think COVID-19 has demonstrated the indispensability of using technology in medical education and in education as a whole. The second thing is that we're going to redefine the community. So all these other programs have community health, and all of them, without exception, define community health as going out into a rural or peri-urban community to understand what the health needs are. We are redefining the community to include urban communities as well as the peri-urban and rural communities, recognizing that each of those communities have unique health needs, some of which are geographic, but some of which are cultural, some of which are socio-political, that we as health providers have to become aware of right from the beginning. Another key thing that is required in medical education that we don't have enough of is interprofessional education, where you have various cadres of health professionals beginning their educational careers in the same classroom, in the same setting, understanding what each other's roles are. And finally, I think one of the other things that we will be introducing here is our curriculum is going to leverage social sciences as well. So we appreciate that health professionals do not operate in a hospital environment alone, and they do not operate in a vacuum. They operate in a social environment that has a history, that has geography, that has culture, and that we have to understand and appreciate if we intend to be effective even at the individual patient level. So our curriculum is designed to take advantage of all this because we already have them, and produce a health professional who appreciates all this and therefore is able to operate in this environment. A caveat that I would put forward at the moment is that our curriculum is at the moment under review by the regulatory authorities. The Medical Practitioner Dentist Council has already looked at it and given comments that we're working on. And the Commission for University Education is also in line to give approval before we can actually make an official announcement for the program. We are putting in place the infrastructure at the new university center right across the road from the hospital, where we will put in place state-of-the-art infrastructure to deliver holistic health education to our students. And we will continue to use our state-of-the-art hospital that is already delivering high-quality care as the laboratory in which we will forge these professionals who will, in our view, change the healthcare landscape in East Africa and in the world.
That's a lot, and that's really ambitious. But you have touched on something, talking about the interprofessional aspect of embodying and including others into it. And we've seen that one of your strengths has been in terms of international collaborations and how those can strengthen an institution. If we can touch on some of the sensitive areas of medical healthcare within East Africa, for instance, the unemployment issues, the nursing ratio, what do you think are some of the underlying challenges that are creating some of these dynamics in terms of preventing better healthcare within the region?
I think 20, 30 years ago, we had a problem of shortage of health workers across the region and probably the entire continent of Africa. And we used to use a metric called, health worker per population to determine whether a country has a good number of health workers or not. That metric is now outdated in my view. And the metric that we should be using is flipping it, to look at how many people in the population who need certain health services are able to access those health services in a way that satisfies their need. And that metric hasn't been used yet. But if you use it, you'll find large segments of East Africa where people have absolutely no access to health services of any shape or form, and who die from preventable causes and who get sick from preventable causes. So today, paradoxically, we have increased numerous times the numbers of health professionals that are being trained in this region. In Kenya alone, there are thousands of doctors being registered every year as new doctors starting internship and being distributed across the land. And the same situation occurs in Tanzania and in Uganda, both graduates from the region and graduates from elsewhere who are coming back home. So the problem is not at the moment one of acute shortage. There is still insufficient numbers, but it is not an acute shortage as it was 30 years ago. The problem now has become maldistribution and underemployment. So we have cases which are completely paradoxical of large numbers of health workers who are either unemployed or underemployed in countries that have people who have little or no access to health services. So this is a challenge of the public health system to start rationally identifying where the needs are and distributing health workers to address those needs in the population. And this calls for a flipping of that model, as I said, from looking at how many doctors do we have per population to looking at how many people in the population are able to access an obstetrician when they need one, how many are able to access primary healthcare worker when they need one, how many are able to access a midwife when they need one. And then you start seeing where the problem is in this region. If we continue counting doctors per population, nurses per population, health workers per population, the numbers keep growing, of course, and we keep getting more and more comfortable that the ratios are improving. But the people that need to access the services are not accessing them because of fragmentation, because of maldistribution that is endemic in the East African region.
That's very interesting. So I can see a lot of your training or your exposure to the community aspect, that it is how many can we reach versus how many as an average in a nation are touched upon this. Coming closer to home, the Ministry of Health in 2019 had this task force on mental health issues, and they actually recommended a mental health commission and happiness. We know Kenyans view mental health issues as some sort of problem and disorder. You're even laughing at that one. You're quite familiar with that. And it has been recognized, particularly in the last year, that depression and anxiety are growing concerns. Our chancellor has mentioned that that is an issue. Non-communication, communicable diseases is a rising issue within our nation and within this region. How do you think the Medical College of East Africa is going to address that?
Firstly, and I fully agree with our chancellor, I think he's spot on in looking at non-communicable diseases as the great challenge of our times. Most of our societies, and especially in East Africa and in Africa, are transitioning from a disease burden that was characterized heavily by infectious disease, malaria, diarrheal disease, HIV, and so on. And we're transitioning into a new pattern that is heavily populated by non-communicable diseases, including cancer, hypertension, diabetes, and importantly, in my view, mental illness. And so it was pretty gratifying in my view when in 2019, June 1st, the president, during a Madaraka Day address to the nation, indicated that the government had determined that mental ill health is a crisis in this country. He specifically mentioned problems like suicide, substance use, depression, anxiety, and so on as being things that we must now turn and start addressing head on. And he directed the Ministry of Health to set up a mechanism to advise the government on how to start tackling these problems. The Ministry of Health then proposed a task force, which the president accepted and appointed, to study this problem and come up with workable solutions. I was privileged to be a member of this task force, and we served in the period that we were given between November and February, March of 2020, when we completed our report and had it in the first half of last year. In that report, we made far-reaching recommendations to the government, including beginning at the top, looking at the National Referral Mental Health Hospital, Madari, and saying it needs to be brought down and rebuilt as a facility that accords people care with dignity for their mental health, and a facility that is seen as a place where if I got a mental illness, I would go to, rather than run away from as if it is a jail. We recommended, as you said correctly, a national commission on mental health and happiness. And it was very deliberate that we think the mental health of a nation is inextricably tied in with the happiness of that nation. If you mess up with the mental health of a nation, you increase unhappiness. And you increase unhappiness, you worsen mental health, and you worsen everything else after that. The education system will not work, industry will not work, agriculture will not work, the economy will tank when you have a population of unhappy, mentally ill people. And so this commission's task was, other than advising on mental health interventions that need to be put in place to improve the mental health of the people, it also was tasked with tracking the state of happiness, because there is a happiness index that can be applied every year and to see whether there's increasing happiness or reducing happiness. And this happiness has been correlated elsewhere with economic prosperity, with more cohesiveness, with more political stability. And these are all the things that any human being in Africa, in East Africa, in Kenya would want to happen in their lifetime. Looking at mental health in general, mental health is not just mental illness. Many people think that it is only mental illness. That's why when we mention mental health, everybody starts thinking about, this rowdy person in the street picking rubbish and so on and so forth. But mental health is a spectrum, beginning from people on one end with good mental health, people who are well adjusted, people who are able to address challenges of day-to-day living with equanimity, people who are living well with the community, people who are achieving their lifetime goals. And it runs a spectrum to distress, when things start going wrong in your life and you start having a little difficulty, to illness, when you develop signs and symptoms of mental illnesses on one end of the spectrum. And we have severe mental illness on the other end of the spectrum, which constitutes perhaps 1 to 2% of the general population have severe mental illnesses, including schizophrenia, bipolar disorder, and so on, that then require urgent interventions and might require hospitalization and the facilities that we talk about. But most mental health happens in the community. Promotion of mental health in the community, prevention of mental ill health in the community, and early identification of symptoms and signs of mental illness in the community. And then facilities begin showing up at that top level where people need specialized mental health services that we then offer. The Medical College East Africa is contributing significantly to this and in attaining these recommendations of the task force. One of the things that we have done over the past year or so is that we are establishing a Brain and Mind Institute. And the Brain and Mind Institute will be tasked with a number of things, including research to generate new knowledge that will then inform policy and advocacy in mental health, supporting academic programs. And already we are supporting the School of Nursing and Midwifery to develop programs around mental health nursing, and later working with the Medical College to establish residency programs in mental health and other postgraduate programs, but also supporting the undergraduate programs to have mental health components. And the third thing that the Brain and Mind Institute will be involved in is in supporting care by providing evidence that helps mental health workers to do work that is of high quality. Importantly, the Brain and Mind Institute will be involved in advocacy. And one of the most important initiatives that we are already starting to get involved in, even in the formative years, is in suicide prevention. And there will be a number of events in the coming weeks around suicide prevention and advocacy. Our goal here is to decriminalize suicide so that people who feel suicidal feel free to come and get help, rather than hiding it and keeping it to themselves and eventually taking their own lives because of the stigma around this. So the Medical College is completely intertwined with the activities that were proposed by the Mental Health Task Force, but also in implementing, supporting the government to implement the mental health policy that guides all these activities that we do. I was privileged last year to be appointed by the President of the Republic to chair the board of the Mathare National Teaching and Referral Hospital as part of the transformative effort in recognition of the decisions that AKU makes. In the sense that most of the leadership in AKU in Kenya are serving on one board or another. And I was privileged to serve on the board of Mathare Hospital, which we are also working to transform in order to address the needs of the people in Kenya and in East Africa.
That's fantastic to hear, Prof, particularly working with Mathare and having your expertise and bringing some of that knowledge to us and sharing what we have as well. For instance, in the Brain and Mind Institute, that is really, really intriguing. Your reference to the happiness index, we've seen the Scandinavian countries leading that for the last few years. And on a lighter side, I wonder if it's because they have a lot of saunas over there. But you've mentioned it has quite a bit to do with the prosperity of the nation going forward. But mental health issue has really raised its head in the last year. Mental health care professionals have really risen more to prominence in the last year because of the pandemic. And we've seen some of the short-term effects. What do you see as some of the longer, uncalculated long-term effects on our children, on us as professionals working on this two-dimensional platform? Do you have any insights about that, and how are we able to cope with that?
So at the beginning of the pandemic, when it was rising in March of last year, analyses were carried out on the kinds of waves that we are going to expect that will affect human society as a whole. There were the obvious waves of illness related to the COVID-19 virus itself, that we have seen numerous of them. In Kenya, I think we've experienced 3 or 4. There was the economic impact, of course, because of the effects of control, including lockdowns, including a cessation of movement, including cessation of economic activities and so on. There are other issues, including chronic illnesses that would emanate as complications of the COVID-19 pandemic itself. But importantly, we identified mental ill health as one of the both short-term, medium-term, and long-term consequences of this pandemic. Some of the consequences would be due to the direct effects of the virus itself on mental health and on the brain and its functioning. And we have already seen the neuropsychiatric manifestations, and a lot of papers are being written on this. The other manifestations would be, secondary to the losses that we have all experienced during this past 1 year or so of the pandemic. And these have affected people's coping mechanisms, and we have seen a lot of people who are vulnerable to mental illness, succumbing to mental illness, getting sick. You've seen, people contemplating suicide after those losses and so on. There are long-term consequences that are related to the interventions that were put in place to control COVID-19. We have limited human interaction. We have changed how human beings look like. In public, people now have half a face rather than a full face, because you've covered the rest of the face with a mask. We have limited how we interact with strangers. We are fearful of strangers because we do not know who will infect the other. We are changing how we socialize. We are changing how we celebrate birthdays and other events. And this will have an effect on our mental health. We are social creatures. Our mental health thrives when we get together, when we share ideas, when we share meals, when we share drinks together, and when we share activities of a celebratory nature. We have a hormone in our brains that is produced that thrives on connecting people. And when we get more connected, this hormone is produced more and we feel good. It's a feel-good hormone. And so this has reduced. And as you can imagine, happiness therefore has been affected. And as you can imagine then, unhappiness and the consequences of unhappiness are increasing. We are going to see a lot of this, and we have to plan as society how we are going to tackle this over the coming 5, 10, 15 years, even if this pandemic is controlled within the course of this year.
Therein the importance more and more for the Brain and Mind Institute and some of these new innovations you're bringing in about, and medical education 3.0. It's the techie side of you is kicking in, eh?
Yes.
Kenya is growing at a population rate of about 1 million people per year. and the rest of East Africa. It is an area that the population is growing rapidly. The microtrend says that Kenya is using approximately 9K per person in terms of healthcare. Uganda is using about 5,000 Kenya shillings and Tanzania about 6,000 shillings. Malnutrition has also been identified as a leading cause still within this region. How is the Medical College of East Africa addressing these matters of public health? They're central in terms of maternal and child care, healthcare, and care of women and the elderly. How do you think we are going to handle this moving forward?
So the Medical College East Africa has a footprint in Kenya, a big footprint in Kenya and Tanzania, and activities in Uganda that will build up into more activities in Uganda as well. So we preparatory phases. What is our role? We see ourselves as a beacon, if you like. We see ourselves as sitting at a place where we can demonstrate to our region and to the world what is possible in this part of the world. We see ourselves as demonstrating that despite not being as wealthy as other countries in the West or other countries elsewhere in the world, that we are able to deliver the highest possible standard of healthcare to the people in our communities. So we can demonstrate to the governments in the region what is possible. And we ask what is possible. We challenge the idea that people who are poor, if you like, or less socioeconomically endowed, do not deserve the best care available. And we have set ourselves a task, therefore, of demonstrating that it is possible to address these issues without bankrupting the country, but in fact, by placing the country on a trajectory of economic growth. A lot of the problems that you have enumerated, malnutrition, diarrhea, if you like, chronic conditions that we are experiencing, infectious diseases that should have been eradicated thousands of years ago, like cholera, are because of maldistribution of the resources that we have. If we in this region stuck to our promise several years ago in Abuja, where our countries congregated and the governments promised to spend 15% of their health expenditure on health, if we did that, we would start chipping away at some of those problems. We would provide clean drinking water to all our populations. We would ensure they have access to nutritious food. We would ensure that the air quality is such that people are not exposed to toxins. And we would ensure that those that start getting unwell while at home have quick access to health services that ensure that they are able to return to productivity very quickly. And we can do this by investing very deliberately in health interventions beginning at the community level, including encouraging physical activity, encouraging farmers to farm healthy crops. I would be one of the people who would say, go into the areas in East Africa where people are growing tobacco and uproot that tobacco and replace it with cassava, if you like, replace it with the millet, replace it with indigenous foods that would serve our people, instead of this tobacco that we will make 2 shillings and then spend 20 shillings treating the consequences of tobacco, and so on and so forth. So I think we are able to spend our shillings more efficiently and more deliberately to deal with the health of our people. Importantly, I think we're very fragmented in our health systems in East Africa. Kenya, Tanzania, Uganda, we do not speak with each other as much as we should as an East African community, and as far as the health sector is concerned. Within Kenya, we have fragmented the health system 47 times. And we keep singing the mantra that health is fully devolved, even though we know that it is a shared function between the national government and the county governments. And both of them, both levels, have huge responsibilities of ensuring that Kenyans stay alive and healthy between birth to death at a ripe old age, so that they can then do all the other political things in between those 2 points in their lives. So I think we have a responsibility to demonstrate how to keep people healthy and to call out those responsibility holders who do things that keep people unhealthy, so that we keep pushing people back to the right track. And the most important thing at the moment is integration, true integration, where in Kenya, if there's an outbreak in Migori, our counterparts in Tanzania are aware of it, they prepare for it, and help us to deal with it if we have difficulties dealing with it. And COVID-19 has demonstrated the absolute importance of this kind of integration and collaboration as far as health is concerned.
That's fantastic, Prof. And you mentioned one important thing we want to do is demonstrate the possibilities of best healthcare for all without bankrupting the system. The healthcare program that we have, we know is extensive. I've seen the cyclotron, I've seen the wonderful professionals, the doctors, the nurses who are diligent at all they're doing each and every day, and all the staff who are working. But it takes resources, it takes a lot to make this work. How do you think, or what kind of support can the Medical College East Africa ask from partners, foundations? What opportunities do they have to play into this greater vision?
Thank you, Gitonga. This is very important. I think you are absolutely right that you would achieve nothing without resources. And I think our society, our communities, even here in East Africa, have lots of resources. Some of them that we do not recognize, we take for granted. We can tell you that the medical college and our hospital, where we demonstrate things that people only dream about elsewhere, cannot survive without the support of the communities that we serve. We only thrive because the people around us think we are doing important work and come in to support us. And there are very many ways of supporting the medical college and the hospital that we work in. At the medical college, there are opportunities for people to come in and support us through endowments. And these endowments, can be as small as, $100,000, anything that somebody can give and say, I would like this to go towards the training of medical students so that they can come back to the community and support us. Our communities can give gifts. And these gifts can come in the form of anything that you think would be useful in furthering the cause that I have outlined. And there are even gifts that people give, you give future gifts. You can say that I am still, strong, I'm working, I'm earning a pension. But if I happen to die and I still have some money left in that pension, I would like it to go towards strengthening the health system in this region through the Aga Khan University's Medical College by producing professionals who will continue to have an impact on the lives of people several generations after we are gone. And I think there's no greater investment for those of us who look at the bigger picture than investing in the future of your community and in the future of our society. So there are numerous opportunities for giving. There are numerous opportunities for establishing endowments of all kinds. And I think this information is available on our website. And our team is, can circulate this information further.
Thanks a lot for that. We'll see if we can get that link out to share. I think on how to support and how you can contribute both in the short term or long term and otherwise, such great opportunities. There is the African saying, if you want to walk fast, walk alone. But if you want to walk far, you need to go with somebody. And that's what AKU.
Just to add to that again, I think there are also opportunities for people to volunteer their time, to volunteer their expertise, and to mentor. A senior professional can come in and mentor those that we're trying to train so that we keep perpetuating this spirit as we develop the health system in East Africa.
Fantastic. That's a really good one. It's not just in kind, but in person too would be absolutely fantastic. Nothing can beat the experience of a professional in so many years in the field and sharing that with others. This weekend, we have a great event. It's our convocation, and we'll tell you all about that one soon, ladies and gentlemen. But in that same vein, as we graduate more students, where do you see we can be, Prof, in 5, 10 years or something? What is your moonshot? Looking down the line, where can we really be?
Thank you. So founders of medical schools and people who run medical schools think like the ancients who would plant a tree. They would plant a tree knowing that they might not enjoy its shade, but knowing that it will have a shade nevertheless, and that there will be people who will benefit from the shade of that tree. So our horizon is not 5 years. Our horizon, begins, in my view, 10 years from now, 15 years from now, 20 years from now. And in that period, we promise that the healthcare education landscape in East Africa will have changed dramatically. The Medical College East Africa will sit as a shining beacon on how to train health workers who have an appreciation of the environment and have best exposure to the state of the art, but are also relevant anywhere they go, anywhere they find themselves. And to do this, we are going to put in place building blocks, some of which are already in place, that will continue to deliver on this promise long after we are gone. So we are going to have in 10 years, we will already have, I promise you, in 10 years, we'll already have maybe 200 undergraduates who will have already gone into the field, and you'll be able to see them functioning at the highest level. We will have thousands of alumni from other programs that we already have who will be influencing health policy, not only in East Africa, but globally. I would dare say in 20 years' time, there will be an alumni of Aga Khan University's Medical College sitting at the apex of UN bodies involved in health and influencing global health for our people and for the good of society.
That's brilliant and really encouraging for those who are listening and those who are contributing. And it has been a pleasure for me to ask you these questions. Usually, people like me on the other side being probed by people like you, psychiatrists, so good thing you're not probing my mind and I'm probing you. So it's been a real privilege and honor to be able to do that. But this is an exciting time, ladies and gentlemen, because we do want your questions, and we see a lot of them are coming, way more than we thought would come in, but we are really excited, and we're going to dive into those immediately. And the first one I think I have here from my list is from Yasmin, and this is it, Prof. Thank you for your presentation. They visited Aga Khan in 2017 with a delegation of Canadian parliamentarians and were very impressed with the futuristic thinking of the hospital. Your discussion on mental health and depression are really good. And in many countries, mental health is a taboo topic that's been addressed. And we thank you for clarifying the differences in that. The question is this: how are you working to alleviate the taboo in Kenya, as particularly during this time? And we've seen in some nations opioids increase. So how are we in Kenya addressing that way? And how are we going to address it without over-prescribing medication as well?
That's a very good question. Because again, many people think that the solution to a person with a mental health problem is pills. We subscribe to a philosophy of mental health that is the biopsychosocial model. And this biopsychosocial model, which was articulated by George Engels, more than 30, 40 years ago, has it that a person is not only the body, and a person is not only the mind, and a person is not only the society in which they live. A person is a combination of all this. We are biological because we have blood and flesh and bones, but we are also psychological because there's another world of thinking that you can't see. You only see its impact, a world of thinking, a world of feeling, and a world of doing things. And then we exist in a society. We cannot exist in isolation. And that society influences our health, and we influence the health of that society as well. So we are biopsychosocial. And when we develop mental illness, it affects our bodies, it affects our minds, and it affects the society around us, one way or another. Mental illness is one of those illnesses that are not diseases of the individual, but the diseases of the family, the diseases of the society around you. And as we start to tackle it, we have to always keep in mind that the most sustainable interventions in mental health, if possible, would be those that are social, those that are around where you live, who you live with, and how you interact. And the next most sustainable would be psychological ones, because they will have a lasting impact on how you think, how you feel, and how you behave. And the pills come in to support those two areas, not to replace them. So people use medications, especially if somebody is agitated, they will need some medication to calm down so that the other interventions can kick in. Medications are not a solution in themselves even now, and we do not have perfect medications even now. Perhaps in future, we will develop therapies that will start acting at the genetic causes of these illnesses, that will start acting at the biological causes of these illnesses to prevent them and to reduce them. But today, social interventions, psychological interventions must be incorporated in the care of people with mental ill health. Now, as far as stigma is concerned, 30, 40 years ago in this country, we couldn't sit in a public forum of this nature and spend 10, 15 minutes discussing mental health. Nobody will be listening. Everybody will say that is a strange illness of strange people and it doesn't affect me and we shouldn't talk about it. Today, we are spending lots and lots of time discussing mental health. And I am happy because over the years, young people have come in and young people are working to chip away at the stigma against mental illness. When I started this advocacy work, I was asked, how can you take this message to young people? Because young people will not take it kindly. They don't see mental ill health as a problem. But we established that mental ill health is the chronic condition for young people. Older people have hypertension, diabetes, and so on, which they live with for their lives. For young people, the chronic illness that they're living with is mental ill health. And the young people took this message. The young people crafted this message, changed it, and made it appropriate for themselves and even for those that are older. And the stigma started melting away when it became okay for them to post on social media that it's okay not to be okay. It became fine to post on social media that today I'm not feeling so well and I don't want to be bothered. It became okay to say, I am going to see a therapist. I'm going to see a psychiatrist. It became okay to say there are online mental health tools that are available that young people and older people can access. And these all open conversations when they start chipping away at the stigma, because one of the biggest drivers of stigma is ignorance. People not knowing, not having enough information. And young people have helped to drive this information to a point where mental health is dinner time conversation in many homes. Mental health is policy conversations in cabinet meetings. And mental health is even being discussed in our schools by young children trying to enhance their mental health. So I think we have chipped away at it. We are doing well, but we're not doing as well as we can. We can do better always.
Fantastic. That's a really good one, an in-depth question, because it is a pertinent question. There is a very good question also that has come up from Mr. Titus Mutweri, asking this. We have seen heightened need for rehabilitation services in this country triggered either by abuse or misuse of drugs. What is the position of this country and its readiness to address access to rehabilitation services by the not so financially privileged Kenyans?
Yeah, this is an important question because substance-related disorders do not choose. Many people have thought that it's only the wealthy who can access certain substances and then get ill and go to, but this is a mental illness. And the mental illness doesn't choose which stratum of society you belong in, and these services must be available to all those that need them. As far as the government is concerned, there are a number of rehabilitation centers that are run by public authorities. Madari Hospital is an example. Madari Hospital has had a rehabilitation center for a long time and even has a methadone program for people who are addicted to opioids. And the program has been running for very many years. This is now being, the hospital is now supporting the county in ensuring that people who have these problems have access to substance use disorder care. The Moi Teaching and Referral Hospital in Eldoret also established a rehabilitation center. In Mombasa, there are services that are offered through the Ministry of Health and the county government for people with substance-related problems. It is not enough, but there are already efforts to ensure that this is happening. One thing that can help is for all the county health departments to start looking at the mental health status in their counties and to identify which substances are problematic in their counties and to establish preventive services, to establish curative services for those who start having problems with those substances, alongside other mental illnesses. And we're encouraging counties to do this. And Madari Hospital has been gazetted to develop regional support facilities that will offer high-level specialized services to clusters of counties across the country, so that people, even those who do not have access, who do not have resources, can access this publicly provided high-quality mental health care, including rehabilitation.
Fantastic. We have about 9 minutes, Prof. So let's try do some rapid fire answers to these Wonderful questions that are coming. One of them comes from our own colleague, I believe in Pakistan. Navroz Surani is asking, what level of collaboration do you see with the medical college based in Karachi, a student, faculty, staff exchange or something of the sort?
A1. This is our first port of call for collaboration. We are talking with Dean Adil. We are working together on policy. We're already collaborating in training our fellows, and this is only going to grow.
Excellent. Diana McKay asks, in the area of advocacy for the building blocks of happiness and mental well-being, who can achieve the most impact and drive change? Health sector leaders, government, specific groups with youth leaders? What kind of partnerships are needed?
So East Africa is a young region in the world. I would dare say that up to 2/3 or perhaps more of our population is under the age of 35. And if you leave the young people behind, you'll not go anywhere. So we have to go back to the youth in our region and ask them, what can we do to make your lives happier? What can we do to make the world a happier place? And the young people who I have worked with in the past in exactly figuring out this question have so many answers, you will be surprised. We are working on a framework with the Cities Rise organization that I was collaborating with in the past, to demonstrate what are the factors that would make cities mental health friendly, including increasing happiness in the cities and in our communities.
Great. I want to say a special thank you. There's somebody who's actually asked, AKU is a medical college in East Africa. It sounds like it has a very ambitious agenda, which will benefit so many more people, especially around access. I grew up in East Africa and where I was educated at Aga Khan schools. I now live in Canada and would like to financially support the work of AKU. Thank you. Does AKU accept gifts of one's estate? Yes, it does, and we will contact you directly and share that information. And we really thank you for that contribution in helping us go forward. A very interesting one, and this is at its starts, Prof. As a young person, I have a question about the increasing fear, worries, and concerns due to COVID-19 and its impact within the young population. Most of my peers have lost their jobs and various sources of income. From these, there is increased levels of loneliness, depression, harmful alcohol, drug abuse, self-harm, and suicidal thoughts. Any positive insights on how to deal with this issue will be appreciated.
Yeah. So there are numerous resources available online to support young people who need to see how to deal with the stress, how to deal with the challenges of COVID-19. Some of those resources are available on the Ministry of Health website, which we developed, and they're available there. Support also is available on the Ministry of Health website for people who require to know where do I go and so on, including online resources, some of which were being supported by the Kenya Red Cross, for where you can call and get quick advice. But I would say this as a message of hope for the young people. We will transcend COVID-19. We will go beyond COVID-19. Things will improve. We will control it. And the world that emerges after COVID-19 will be a world that is imagined by the young people. So right now, as jobs are lost, it is time to reimagine the work environment, reimagine jobs, start thinking about opportunities that are emerging during this COVID period and that may emerge after the pandemic. And if you can think about solutions to problems that will be there in that time and start generating solutions now, you will be well placed. You will be on top of the game when this pandemic is behind us and everybody's looking for opportunities in the economy. So there is hope. There's lots of hope with the current interventions that we are doing. Things will only get better.
Thank you for that message of hope and pointing us to some sources that we can get professional help. Muhammad asks this. Thanks for the very educative presentation. My concern is about the mental illness and especially those who have mental problems and have ended up in the streets with nobody concerned about how they can access healthcare services. And do you have any plans to mop these people up in the streets? What solutions are there?
So the solutions that are there are social solutions. All of us in society must start becoming more responsible for our own people and our relatives. It is a rare day that you will find a person who has been knocked by a car and is bleeding on the roadside and nobody's talking to them, nobody's trying to help them. But it is common for us to see a person who is mentally ill basically crying out for help in the streets, and everybody's running away from them. So it begins from us as individuals to start thinking, what can we do to support those of us who are going through mental difficulties? How can we help them access the nearest help? And the infrastructure is there, but it requires action by individuals in society rather than waiting for, say, hospitals to go out and look for people with mental illness and lock them up. That is not a sustainable solution. It has to be done in the community by us taking the first step of finding out how can we help this person that we are seeing in the street who looks helpless and who looks mentally ill.
Thanks for that one. One of ours, Dr. Joy Mugambi asks this. Kenyans are quite angry, and we see this on the road strikes and general engagement. So the question is this: is there room for us to start to debrief and counseling in offices and schools? And how can we go about doing this as management?
Yeah, so I'll split that two ways. The second part, is there room for us to provide mental health support, mental health services for workplaces, for schools, and for other institutions? Yes, yes, yes. We have to set that up. And if you have an organization that you're running that has 10 people in it, you have to ensure that they have access to mental health services and to psychological support. Yes. The first part, Kenyans are angry, indeed. And many people in the world are angry, surprisingly so. But then if you look at how things evolve, anger can be channeled. We can identify what is making people angry. And often what is making people angry is the frustration that things are not going as well as they should, and that their personal individual effort is not yielding as much results as they would like to. And I think national governments and the leadership that people elect have to start getting, coming alive to this anger and thinking about how to address it, how to channel it so that we can improve our social circumstances, rather than letting it to fester and cause individual injury in the people who are angry themselves. So there are ways of doing this, and political establishments know, and if they do not know, there are experts who can advise them on how to channel this anger in productive ways that make progress for society as a whole.
Fantastic. The last question, Prof, 1 minute for this one. Alcohol, for some, mental illness and a destroyer of communities and societies. On the second, a source of income. Is there a way to balance this? Is there a way to challenge this situation? This is from Consolata.
There's always a way of doing this. For instance, and I'll begin with tobacco. It was a huge source of income for many parts of the world. But today we agree that it does more harm than good. If we determine the same way that alcohol as a whole does more harm than good, we will find alternative sources of income for those that depend on alcohol for source of income. I would argue that our first port of call should be the health of the people. And if we find something that is harmful to the health of the people, even if somebody is profiting from it, they must find an alternative existence away from something that is harming people.
Thank you so very much for that. We are just about out of time. I see your questions, Rahima. I see your comments, Judith. Zul, I see your comments. Simon, I see your comments. And I really want to engage and delve with them, but we have to respect your time as well. And we said this would end momentarily. Prof, one final parting comment before I close out.
I want to thank everybody who has made time to be with us today, and want to reiterate the promise of the Medical College East Africa to revolutionize health professional education in this region and produce professionals who will go out there and change the world. Thank you very much, Gitonga.
Thank you very much for that, Prof. Ladies and gentlemen, this weekend, we will be celebrating a momentous time in an institution, and anybody in education knows that. Convocation, our graduate of our students in nursing and midwifery, in communications and in media and communications, in the medical college, we will be celebrating this weekend. That is our convocation, in which our special guest is going to be Melinda French Gates. Yes, and actually, His Excellency the Chancellor will also be addressing us. That is, the Aga Khan will be addressing us during the convocation. I am sharing the link with you right there. There is a website, convocation.aku.edu. Please visit the website and see what is going to be there. Technology has allowed us to celebrate these occasions wherever we are, in the morning, evening, afternoon, across the world. We do encourage you to join us. That being said, we are so grateful and thankful that you could join us this afternoon for the pandemic disruption, looking at the future of public health in East Africa. Your positive comments, suggestions, recommendations, critique are all invaluable. To the technology team at GSMC and AKU, to Fatima and the team, to Dr. Atwoli, and especially to you, ladies and gentlemen. Thank you for joining us and have a wonderful morning, afternoon, or evening. Goodbye.
Thank you very much and goodbye.